Hello everyone, I am Dr. Vidhu. Today we will continue our oncological emergencies. We will start with the first topic, hyperleukocytosis. So in this, 10 to 20% of children with acute leukemia can have WBC count of more than or equal to 1 lakh per cubic millimeter, which is arbitrarily taken as definition of hyperleukocytosis. So children with acute leukemia presenting with WBC count of more than 1 lakh are said to have hyperleukocytosis. So in this, the leukemic cells will be larger than the normal cells in size. So they are larger than the normal cells in size. So thus it will lead on to increased viscosity in the blood. So there is increase in viscosity of blood, plus they lead to adherence to the endothelial cells of blood vessels. So thus this causes sludging of the blood or sludging of the cells in microcirculations. This term leads to leukostasis. So this leukostasis finally causes end organ damage. This end organ damage is particularly present in brain and lung. Okay. So this is the consequence of hyperleukocytosis. There are some leukemias which are prone to have the hyperleukocytosis. So risk. So what are the leukemias that is other risk are infant leukemia, second ALL which are T cell type, AML which are monocytic. So these are prone for hyperleukocytosis. These hyperleukocytosis need to be differentiated from first leukemioid reactions. These leukemioid reactions occur due to infections such as staphylococcal sepsis and pertussis. So what are the points in favor of leukemioid reactions are, in this you have WBC count less than 1 lakh. Second, focus of infection will be present. Third, in peripheral smear there will not be atypical cells. So there won't be any atypical cells or blast cells. You can see mature cells. So it shows the peripheral smear shows mature cells. Okay. So this is the difference between leukemioid reaction and hyperleukocytosis. Second, you should also need to differentiate this from children having thalassemia major. In thalassemia major, there will be a spurious elevation of WBC. So there is a spuriously elevated WBC. It is because the nucleated RBCs are falsely counted as WBCs. Okay, so you have to differentiate the hyperleukocytosis from a child which is having a leukemia reaction or a thalassemia major. For this, for every child when you take a CBC, when it has a WBC count of more than 1 lakh, you should order a peripheral smear. So therefore, CBC with peripheral smear is mandatory to confirm the diagnosis. Okay, so this hyperleukocytosis is often associated with tumor lysis syndrome. So this is associated with tumor lysis syndrome. Okay, so you have to do before doing the main intervention, you have to take care of airway, breathing and circulation. This everything should be stabilized. You have to do a fundal examination to rule out papilledema and retinal hemorrhages. You also should take chest x-rays to look for any infiltrations. Okay, so what is the treatment for this hyperleukocytosis or when the WBC count is more than 1 lakh? You should give a vigorous hydration. So vigorous hydration, this is as I told in a previous video, that is in the tumor lysis syndrome. So vigorous hydration and following the same steps in tumor lysis syndrome. Okay, next you should maintain the platelet count of more than 30,000 to 50,000 per cubic millimeter. Third, PRBC, that is packed red blood cell transfusion, is typically avoided. So this PRBC transfusion is avoided till the WBC count is brought down. Since if you give a PRBC transfusion when a child is having a hyperleukocytosis, it can increase the viscosity. So PRBC transfusion is avoided. Fourth, leukoreduction. So this leukoreduction is vital or the key element in hyperleukocytosis. So this is the vital in hyperleukocytosis. Okay, so how this leukoreduction is done? So for this leukoreduction to be done, you should need a speedy diagnosis and you should initiate the treatment in the leukemia. So you should initiate what? Chemotherapy. That is, you should initiate steroid in child with ALL and cytarabine in child with AML. So when you initiate this therapy, steroid in ALL and the cytarabine in AML, this can reduce the WBC count within 48 to 72 hours. Okay. Fifth, or you can do leukapheresis by using the monitored apheresis machine. Sixth, you can use partial exchange transfusion if the HB is less than 6 gram per deciliter. So partial exchange transfusion is done if the child has anemia with hyperleukocytosis. So this is the management for hyperleukocytosis. First is vigorous hydration and following the same steps as in tumor lysis syndrome, and you should maintain the platelet count of more than 30,000 to 50,000 cubic millimeter, and PRBC transfusion is strictly avoided till the WBC count is brought down. So to bring down a WBC count, that is leukoreduction, you should start on your treatment earlier. That is, start with steroid in ALL and cytarabine in AML, which can reduce the WBC count within 48 to 72 hours. Okay, then you can use partial exchange transfusion if the HB is less than 6 gram per deciliter. This is about hyperleukocytosis. Next, second is superior mediastinal syndrome. Okay, so when the mediastinal mass compresses the SVC and airway, it leads to superior mediastinal syndrome. So the mediastinal mass that compresses the airway and superior vena cava, it leads to superior mediastinal syndrome. So when the more than 30% of airway is compressed, it leads to total airway obstruction in children. Okay, so when there is a more than 30% of the airway compression, it leads to total airway obstruction in children. So the conditions or the leukemias that is more prone for superior mediastinal syndromes are, so conditions that is more prone, it can be in non-Hodgkin lymphoma, it is primary mediastinal B cell lymphoma. Again, it can be T cell lymphoblastic leukemia, and it can be in ALL, it is T cell type. Third, or it can be germ cell tumor. Okay. So what are the symptoms you can expect in the child with superior mediastinal syndrome? So there will be a venous engorgement and swelling of the upper part of body. So there will be a venous engorgement and swelling of upper part of the body. Since there is an airway compression, the child can have respiratory distress, stridor, it can present with dysphagia, cough, and they have an inability to lie in a supine position. So they have a inability to lie in supine position. Okay, then how do you diagnose this? Diagnosis simple. You can take a chest X-ray in a PA, and lateral view chest X-ray can be taken, in which the mediastinal mass can be found. If this chest X-ray is not clear or it is not giving a clear diagnosis, and it is not giving clear diagnosis, you can take contrast enhanced CT chest can be taken for the diagnosis. So the patient with the leukemia such as primary mediastinal B cell lymphoma or ALL with T cell type and the germ cell tumor presenting with the symptoms similar to superior mediastinal syndrome, you should avoid the invasive procedures. You should start on always with non-invasive procedures. So non-invasive tests are done prior to invasive test. Why? Because they are poorly, this case will be poor for sedation and anesthesia. So non-invasive tests are done prior to the invasive test. Next, you should do complete blood count with peripheral smear. So if in the complete blood count with peripheral smear, when the blast cell count or when the blast count is high, when the blast count is high, further immunophenotyping characterization and genetic test are performed. Okay. Fourth, side by side, you should look for tumor lysis syndrome workup. Then you can also do serum alpha fetoprotein and beta HCG. This both are elevated when the patient have, these are increased or elevated when the patient have a malignant germ cell tumor. Okay. Or when the patient have a palpable lymph node, that is peripheral palpable lymph node is present, then you can do a FNAC from that, or you can do a excision biopsy. Excision biopsy or FNAC can be done from that. If that is also not possible, or you can carry out bone marrow aspiration under local anesthesia. Bone marrow aspiration or bone marrow biopsy under local anesthesia. Okay. So this is the way you have to diagnose the lymphoma or leukemia in a children presenting with superior mediastinal syndrome. Next, we'll see the treatment for this. First, head and elevation. This head and elevation can facilitate the venous drainage and decreases the airway compression. So it facilitates venous drainage and decreases the airway compression. Second, you have to look for the level of respiratory distress the child has. So as per the respiratory distress, you can give NRM, or you can give plain oxygen by face mask, or you can give HFNC, that is high flow nasal cannula can be done. So do not use sedation and neuromuscular blocking agent because of the risk of respiratory failure. Prophylactic measure for tumor lysis syndrome should be initiated. So prophylactic measure for tumor lysis syndrome should be initiated. You can start on with steroids. The steroids can act efficiently in decreasing this by decreasing the lymphoma or the leukemia in the mediastinal mass. Okay, it can decrease it. Okay, the steroids you can use are dexamethasone can be used at the dose of 6 mg per meter square per day in BD dose, or you can use hydrocortisone at the dose of 5 mg per kg per dose 6-hourly can be used. So you can use dexamethasone at the dose of 6 mg per meter square per day, or you can use hydrocortisone at the dose of 5 mg per kg per dose Q6-hourly. If there is no response to this, if there is no response to the steroid, you can start on with a low dose empirical chemotherapy. So low dose empirical chemotherapy can be started. So low dose empirical chemotherapy you can start on with vincristine plus cyclophosphamide. Okay, so you can start a low dose of vincristine with cyclophosphamide. This may help in tumor reduction and reduction in the distress. This is the treatment management of superior mediastinal syndrome. Okay, thank you. We have talked about hyperleukocytosis and superior mediastinal syndrome. We will discuss about febrile neutropenia as a